our webinar this evening, and which is entitled COVID-19 Update on EULAR Registries and Vaccination. Can we have the next slide? Okay, just some housekeeping rules. Please try, to join with the webinar with your computer. We had some problems with that. Please mute yourself when joining, or you will be muted automatically. Please turn off your camera when joining, as this might ensure a better connection. And if you would like to ask a question, please write it on the meeting chat or send it by email to pare@eular.org. If you experience any technical difficulties, please contact the same email. And our first speaker tonight is Kim Heinrich, Professor Kim Heinrich, who is a rheumatology doctor at Manchester Hospital NHS Trust and a professor of epidemiology at the University of Manchester. The topic that the Professor Heinrich will talk on is understanding the risk of COVID-19 in people living with rheumatic diseases, the EULAR COVID-19 database. Kim, the floor is yours.
Thank you. Just let me share my screen.
Okay. Yes, we can see it.
Perfect. So I realize this is the first time I've ever spoken to PARE, so thank you very much for this invitation. I can't believe it's almost a year now that we've been living with COVID in our lives, and what a year it's been. But one of the more exciting aspects of this year is the fact that I've formed a very nice collaboration through EULAR, and we have established a database which has helped us gain some understanding about COVID. So I'm not going to spend much time talking about the actual virus, because my colleague, Professor Machado, who's going to talk about the vaccines, is going to go into this in a lot more detail, but only to say that COVID-19 is the infectious disease that is caused by the virus SARS-CoV-2. And this is data from yesterday. There's now been 111 million confirmed cases, and sadly, over 2 million deaths in 1 year. COVID is a very challenging disease because it varies between people. Some people can have the virus and have no symptoms at all, not even know that they have it. Most people will have a mild illness. It might not feel mild, but it won't at least need a hospital. Some people will get hospitalized, and sadly, some people will die. When the pandemic started in Europe back in March, we really didn't know how it would be that some people would have a very severe disease and some people could just have no disease at all. And this is why our governments gave us the advice. This is the British government advice: hands, face, space, because the best way to not have a bad outcome from COVID is to not get the virus. So when the pandemic started, there was a really high level of worry that people with rheumatic and musculoskeletal diseases might be at an increased risk of having serious infection. We know that many of our conditions alter our immune system, so the underlying disease itself could make this more severe. And we know that we use a lot of medications such as glucocorticoids and other immune suppressing drugs, which could also make it much more severe. We also knew that for some of our drugs, for example, biologic drugs, they do increase the risk of having a serious infection, but it's not equal in all patients. And for some patients, they do not have an increased risk of serious infections, even with these medications. And we already knew that certain factors such as older age, the use of glucocorticoids or steroids, and the presence of other comorbidity can increase your risk of having serious infection. Be this because you can't control the infection because your immune system is suppressed, or if you do get a severe infection, you have less capacity to cope with it because you have other diseases such as lung disease. So I'm going to talk a lot about risk, and what I like to do is just take a couple minutes to review with you how we actually research risk. what I'd like you to do is to imagine this to be the whole population. And within this population, some people will get COVID, some people will get severe COVID, and others won't have it at all. What we can do is, as an epidemiologist, which is my research specialty, is we can look closely at that population and we can categorize people whether or not they have certain features. So for example, we have a group of people here who are purple, and we have a group of people who are green. What we can do is we can look at whether the risk or the rate of getting COVID, for example, is different between green people and purple people. So in my example, we have 10 out of every 100 purple people get COVID. So it's a 10% risk, or 1 in 10 people. But 12 in every 100 green people get COVID, 12%, or about 1 in 9. We then tend to like to talk about relative risk, where we look at the risk in one group and we divide it by the risk in the other. So we get the relative balance of risk. So in this case, 12 divided by 10 is 1.2. which we interpret as green people are 1.2 or 20% more likely to get COVID than purple. I've chosen purple and green because I'm pretty sure there's no one that is those colors on the call right now. We then like to present risk using graphs. This here is the 1.2 ball here. This red line indicates that there's no difference between the two groups. Any balls that are above here indicate that the risk is higher in one group over another. If the ball is below, it means that the risk is lower in one group versus another. And if it sits on the red line, it means that there's no difference in risk at all, or it's the same. The final thing we consider is whether or not we are confident. So it is impossible to study everybody in the entire population. So what we do is we take a small selection of people and we try to say what we believe this group of people will represent the entire population. And what we do is we put these confidence bars around our estimates. The shorter these bars are, the more confident we are, because we feel that most of the time, if we were redoing our experiment or our study, the ball would fall somewhere between these green bars. So in this case, we're very confident that the risk is increased, whereas on this case, you can see that the bar is very wide. And it's possible next time we repeat this, the ball is on this side. So we're not very confident at all. As I go through some of the findings from the research that we've done in the last year, a lot of our attention is going to focus on our confidence in what we are saying. So we have two main questions about COVID in patients with RMDs. Are people with RMDs more likely to have severe COVID if they're infected with SARS-CoV-2 compared to people that don't have RMDs? And are some people with RMDs more likely to have severe COVID compared to other patients with RMD? So does the risk of severe COVID differ between the different RMDs, for example? And does the risk of severe COVID differ between different DMARDs or different treatments, for example? So I wish I had a really clear answer for this first question, but unfortunately, the answer here is still unclear. And it's unclear for a few reasons. First of all, we don't have good samples of patients that have RMDs with which to compare to those that don't have RMDs. We also don't know the true extent of SARS-CoV-2 infection in the population. I live and work in the UK, and for the first 3 or 4 months of this pandemic, there was no testing in the community. So people may have had COVID, but for those that had more unusual or no symptoms, they just simply didn't know. So we don't have these data sets. The other thing to say is even if we did have this data set, we would come up with a single answer that either all people with RMDs have an increased risk or they don't. And it's more likely that the risk varies between individuals. So a simple yes or no answer really doesn't help our community to understand the risk. So therefore, our attention over the last year is focused on whether or not some patients with RMDs are more likely to have severe COVID should they acquire the infection. And we did this in EULAR by establishing something called the EULAR COVID-19 database, which many of you may have already heard of. The database is set up such that if there is a person that develops COVID, whether it's asymptomatic or the worst case, they die from COVID, and the rheumatologist learns about this patient, she enters it into our COVID database online. And then once we have enough patients, we can analyze this to look for those patterns to see if there's certain groups of patients that have higher risk than others. And this database was set up in partnership with something called the COVID-19 Global Rheumatology Alliance. This is an international, global rheumatology community group that has come together to establish an international database, which includes patients. Ideally, they could be from any country in the world. And this is data from just recently showing that now within this database, there's almost 11,000 patients with RMD, all of whom have had COVID. The global case database therefore consists of patients with COVID-19 from the GRA, as well as any patients that live within one of the EULAR countries. We also had the benefit of good collaborations across Europe with many of our national societies where they had also established similar databases. So for example, in France, Germany, Italy, Portugal, and many other countries. And those databases worked with us and we shared all of these data into the EULAR database, which then fed into this global case database where there are now 11,000 cases. So unfortunately, this study is not perfect, and it is biased towards more people within this database that have had severe COVID compared to what we believe to be the true rates of severe COVID in the population. So if we, for example, take this as the general population I showed you earlier, there'll be a proportion that has asymptomatic COVID. The majority of people will have a more mild disease. They stay at home and get better. A small proportion will be admitted to hospital, of whom some of those patients will die. Ideally, as an epidemiologist, I would want to have a nice sample of all of these patients together. But in reality, as a rheumatologist, I'm more aware of those patients that have died or who were admitted to hospital because I saw them when I was at the hospital myself. We've heard about a few patients that we have come in contact with through our outpatient appointments, or they've rung our nurses support line. And there's some patients that have had antibody tests now, and we learned that they have had asymptomatic COVID in the past. Therefore, if we only consider those patients that rheumatologists are aware of, you can see very well that there's a very high bias towards patients that have more likely to be in hospital or die. What this means is that the database can't be used to estimate the risk of having severe COVID if you have an RMD compared to no RMD, because there's no RMD-free comparison group, but it also shouldn't be used to estimate what the rate of being hospitalized or dying is should you acquire COVID. But it is incredibly valuable for us to understand the relative associations between different age groups, different comorbidities, different levels of disease activity, different RMDs, and different treatments. So the EULAR database itself, as of the beginning of February, has captured almost 5,000 patients from 32 countries. Remember, I spoke about the bias, and I think this is very clear. Over almost half of these patients were patients that were reported to us because their doctors heard that they were hospitalized, and 11% we had heard about because our patients had died. The European data has contributed to two main research papers now. I'm going to take you through those. The first one was a study that we performed back in May, where we looked at the first 600 patients that were in the global database. So this included both European, American, and other international patients. Again, about half of the group had been in hospital and half had not. We wanted to look at which factors associated with being admitted to hospital. I'm going to highlight for you some of our important positive findings and also some important negative findings. The first thing that we saw, which was consistent with what we know about COVID now for all people, is that age is a very strong risk factor for having a poor outcome. We also know that having a comorbidity is associated with a poor outcome. And we also saw that within our group of patients that had RMDs. So high blood pressure, lung disease, diabetes, kidney disease, for example, you were more likely to be hospitalized if you had one of these conditions than if you were not. And you can see that this is fairly confident about these associations. We then looked to see whether there were any differences within patients that had RMDs related to their underlying comorbidity. And you can see here that overall, there were no real differences. We had no confidence to be able to say with certainty that any one RMD was more likely to be admitted to hospital than another. One of our positive findings was the finding that patients who were receiving higher doses of glucocorticoids, here defined as more than 10 milligrams, were more likely to be admitted to hospital. But we showed quite certainly that there was no association with hydroxychloroquine. So despite everything Donald Trump tried to convince of us, he was again wrong. This is a paper now that is going to take us through a lot more detail looking at RMD disease activity and treatments. And again, this is an international paper that included patients from around the world, where we looked at factors associated this time with death. The paper included 3,729 patients with RMD, all who had acquired COVID. Again, there was a bias towards a higher proportion of patients who had died. So about 10% of this population were patients that had been admitted to hospital. Had died. We were able now, due to the size of this study, to include a wider range of conditions. So I'm going to show you results that look at all RMDs together, but also for inflammatory joint disease, which includes both rheumatoid arthritis and spondyloarthropathy, and adults with JIA, rheumatoid arthritis alone, connective tissue diseases here grouped all together, lupus, vasculitis, and others, and then other conditions. We are also going to look at a lot of different treatments. And in this case, what we decided is we would compare all of our drugs to methotrexate, with methotrexate for most conditions, at least the inflammatory joint diseases being our main treatment of choice. And you can see now we have a very wide range of patients. So almost 1,500 patients with rheumatoid arthritis, combined over 800 patients with spondyloarthritis or psoriatic arthritis, almost 400 patients with lupus, 500 patients with other connective tissue diseases. Again, we saw that age, particularly older age, over 75, was one of the strongest associations with poor outcome, in this case, death. However, for the first time, we also found that there was a strong association between dying and patients who had uncontrolled disease. You were more likely to be one of the patients who was reported to have died if at the time you acquired COVID, your disease activity was high. We again saw no real difference between any of the connective tissue diseases or other arthritis compared to rheumatoid arthritis. Again, we had no confidence to say with any certainty that there was any differences between these. Then we went and we looked at all of the treatments. Again, remember the bar down the middle is methotrexate, and this time the graph is flipped on its side. So anything on this side is associated with more likely to die, and anything on this side with less likely to die. The first important thing to note is across most of these treatments, there is no difference with methotrexate, suggesting that most of our treatments are not associated with an increased risk of dying from COVID. There were a few that stood out, however. The first was rituximab, and this actually didn't come as a surprise because rituximab blocks B cells, and B cells are important in developing immunity to infections. So it's very possible that in the absence of the ability to generate antibodies or immunity to infections, people were more likely to have uncontrolled disease. We also saw an association with immunosuppression. Now, immunosuppressives aren't used very often. These are drugs like cyclophosphamide, cyclosporin, azathioprine, more likely used in connective tissue disease. But when we looked within the connective tissue disease, we did see a slightly higher rate of dying. And finally, and perhaps somewhat of a surprise, was this finding of sulfasalazine. This was unexpected because we don't believe sulfasalazine to have a strong association with infections. We do know, however, that sulfasalazine is often reserved for patients that can't have methotrexate, and one of the main reasons is comorbidity. So it's possible that this isn't a relationship with sulfasalazine, but more a marker for something else. So I think the project has been a huge success. The participation across Europe among rheumatologists has been unlike any project I've been involved with in over 20 years as a rheumatologist. So it's been a very rewarding opportunity to work with. And I've got some main take-home messages from what we know so far. The first is that for most people, the factors associated with hospitalization or death from COVID-19 are the same for patients with RMDs as they are for the general population. We need to make sure as rheumatologists that we work with our patients to ensure that their disease activity is under the best control. Because one of the findings was that patients with high disease activity, when they acquired infection, were more likely to be in the group that died. We have seen some associations with some of our treatments, but most treatments have no difference in outcomes compared to methotrexate. Most importantly, it's to not stop your treatments. And if you do have any concerns about any treatments you're taking, really this should be discussed with your rheumatologist, as we have to remember that controlling disease activity should be our priority. That said, it may identify some groups of patients that perhaps we should prioritize for vaccination in countries where the rollout has been slower. And finally, the majority of people with RMDs who acquire COVID do well. So that, I think, should be the most positive message that we have, despite the fear that we all live with this infection. So I'd like to acknowledge the wonderful team that we've worked with, all of the national societies, the Manchester University data team, EULAR, PARE, and the Global Rheumatology Alliance. So thank you very much.
Thank you very much, Kim. That was very interesting. Any questions from the audience? Well, I have a question then. You've showed us, Kim, at the beginning, the numbers, the people who got infected and also the people who died. And the numbers are large. We hear that some people say that, well, it's like any other flu. It's just that they are giving too much publicity to it. And people from normal flu die as well. It is not known. What is your comment on that?
So, I think it's very dangerous to compare this to regular flu. Flu does kill people every year, and it kills a lot of people. But unlike COVID, we have until perhaps a few months ago, there's a vaccination for flu. So flu is a preventable illness, which we don't have for this. The other thing to say is, yes, for some people, this will be a mild illness, but we still cannot predict who this won't be a mild illness for. And there are young people that have died. I have a colleague who was pregnant and had a devastating course. And we have it's estimated about 1 in 10 people will have long COVID, which has symptoms that are very similar to, say, fibromyalgia or chronic fatigue. And these are previously young, fit individuals. So I think this should not be discounted. And it's just very unfortunate that the only way to control this has been to stop us seeing each other.
Thank you. Have a question here in the chat. Do we have any knowledge about the people who are using JAK inhibitors and their reaction to COVID?
So we have patients within the EULAR database that have received JAKs, primarily for rheumatoid arthritis and psoriatic arthritis. When we did our first analysis, unfortunately, there were very few people who are using JAKs, say, compared to anti-TNF, where we had many thousands almost of patients. So we've not yet been able to undertake that analysis with any certainty to be able to say so. But we're hopeful now that there are over, so there's 10,000 patients now in the database. And we've also formed collaborations with people doing similar projects with inflammatory bowel disease, so Crohn's disease and ulcerative colitis, and psoriasis. And they also use JAK. So we're planning to undertake an analysis where we can bring all of these people together to study some of the less common exposures. And I would say that's the same for interleukin-6, like tocilizumab, IL-17 inhibitors, such as secukinumab and ustekinumab, where we need to combine forces.
Thank you. A question from Ofra. Are the vaccine okay for the RA patients in long term? I'm not sure.
So I'm not going to answer that now because I believe Pedro is going to talk about the vaccines, and I know that's going to be something that will come up both in his talk and as well in the discussion there. That's okay, Ofra.
Okay, thank you. Any other questions?
I see an okay.
Okay, okay. So another question that I have. You said that patients on biologics are no more at risk to acquire the virus.
So I think that's a very interesting question, because there's two steps in developing severe COVID. You have to first acquire the virus, and then once you acquire the virus, your body has to handle and react to the virus. And so we don't know if being on an anti-TNF makes you more likely to be infected. And it might be that you're actually less likely, because I'm sure, like many countries around the world, which we had in the UK, people on biologics tended to shield or cocoon or quarantine themselves, so they were less likely to acquire the virus because of the anxiety about having severe disease. For those that had COVID, when we compared it to methotrexate, people on anti-TNF biologics, there was no difference in their outcomes.
Okay. And what would you advise a patient who is on biologic and gets the virus to stop the treatment for some time or stay on the treatment?
Well, again, we don't have a scientific answer to that. So our normal advice for patients is if they acquire an infection, we often would advise them to temporarily stop their treatment. We don't know if that's the right or the wrong thing to do. There's now evidence that some of our treatments, such as interleukin-6, tocilizumab, may be beneficial in patients that, stopping these for a short period of time, you're only going to be sick for a few days, really, is probably going to make very little difference, actually.
Actually, I can share my personal experience because I was infected and I had contradictory advice from my doctors. Some advice not to stop my Humira, and some advice to stop, so I didn't, and it was okay. So
I think whenever you get contradictory advice, usually means that no one really knows.
Yes. So another question here in the chat: how much time should elapse after one takes rituximab infusion?
So there's a question about time after rituximab and questions about prioritization. And so again, Susie, if you're okay, can we save the vaccine questions for the second discussion?
Yeah.
But has there been any demonstration of a protective effect from oral or inhaled corticosteroids, given that Dex has been proven to be beneficial in the treatment of COVID? So yeah, so that's very interesting. The use of dexamethasone has been shown to decrease time in hospital from severe COVID. Yet we have evidence from our database that patients on glucocorticoids are more likely to have a severe course of COVID, which contradicts each other. And so one of the things we know, in addition, long-term steroids may work very differently on your immune system from short, high-dose steroids in the acute inflammation setting. So that's one thing to say, that you may be immunosuppressed before you get COVID may be very different than trying to turn down inflammation with steroids at the same time. The other thing we know is that there's a very, very strong correlation between people who are taking long-term steroids and their disease activity. And the higher the dose of steroids, the more likely in our study that you were to be have high disease activity. And it can be very difficult to disentangle the two. Very few patients are maintained on more than 10 milligrams of steroids unless they have active disease.
Okay, thank you. That's another question from Linda. Has there been any demonstration of a protective effect?
Oh, that's the one I just answered.
Ah, okay. Yes, that's the one you answered. The other one is about vaccination.
That's right, yeah.
Yeah, okay. So we leave that for Pedro. Any other questions? I have another question. How long, but this also has to do with, if a person is infected, how long is he immune? Because this is also something that we don't know, and we hear very contradictory views as well. So do we know that?
We don't know. We don't know. So there's a few things we don't know. We don't know how long immunity lasts, although there is evidence from some research in the UK and elsewhere that it could last at least 6 months, if not longer. The vaccines have not been probably studied long enough to know how long the immunity from a vaccine will last. So we don't know. We think maybe at least 6 months. Whether that's different in people that have an immune condition, such as an RMD, is not known.
Okay, thank you. So, any other questions from the audience? Okay, thank you very much, Kim. That was very interesting. There's another question. Regarding steroids, if a person takes one injection every some months, is it considered as a higher risk?
So we don't know exactly. The data that we used was based on the equivalent of oral prednisolone. If the injection is being given for a flare of disease, then it's more important to treat the flare of disease than to worry about the medication. If it's replacing long-term oral steroid use, then I would imagine it would have a similar risk associated with it. So at lower doses, it may be less. Of course, if with an intramuscular injection, it's hard to know exactly how much is there at any given point in time.
Thank you. Okay, thank you very much, Kim. That was very interesting. We can move to our next speaker now, Professor Pedro Machado, who is going to talk about COVID-19 vaccination and the EULAR COVAX database. Professor Machado is a rheumatologist and associate professor at the University College London. Pedro, the floor is yours.
Thank you very much for the introduction. It's always a pleasure to participate in a PARE event. I participated in a couple of them before, and it has always been a very pleasant activity. So hopefully you can see my first slide here.
Yes, we can.
Okay. So just to set the scene, as you all know, the COVID-19 pandemic has caused an unprecedented pressure on healthcare systems worldwide. and there have been a large number of casualties at the global scale, although the large majority of cases are either uncomplicated or mild or moderate disease cases. Having said this, there is still a significant proportion that has to be hospitalized, that requires oxygen support, and unfortunately some of them will pass away. And severe disease caused by SARS-CoV-2 is characterized by a multi-system disorder that, so a disease that affects multiple organs and systems, namely the lungs with pneumonia and acute respiratory distress syndrome. There can be acute kidney injury, there can be thromboembolic events, there can be disseminated infection of the body, and something that has also been described is an hyperinflammatory state, an hyperinflammatory syndrome that can even be more damaging than the virus itself. And in children, although the large majority of children, they do well, in a very small proportion, a severe disease has been described, and that is called multi-system inflammatory syndrome in children. Now, the first point I'd like to make is the distinction between COVID-19 and SARS-CoV-2, because the terms are often either used incorrectly or interchangeably. And COVID-19 is the disease, so it stands for Coronavirus Disease 2019, because that's when it was first described. And SARS-CoV-2 is the actual virus that causes COVID-19, and it stands for Severe Acute Respiratory Syndrome Coronavirus 2. And they all the coronavirus, they're a family of what we call RNA virus, and that's because the genetic material that codes the virus, it's RNA, ribonucleic acid. And here you can see the composition of the virus. So the famous crown-like spikes, and that's the spike protein. And then there are other proteins that make up the virus, the M protein, matrix protein, and envelope protein. And inside this protein envelope, there's the RNA material. So the actual sequence of genetic material that will code all the components of the virus. Now, SARS-CoV-2 is only one of many coronavirus that usually infect animals, but 7 of them, they actually are known to infect humans. Now, the first 4 that you can see here, they call the human coronavirus, and then each one of them has a code of letters and numbers. So these 4 have been known for a very long time, and they cause mild to moderate upper respiratory tract illness. So they cause common colds. And they are actually the most common causes of colds throughout the world. So it's not the first time that we've been in contact with coronavirus, and they've been known to cause respiratory infections for a very long time. Now, more recently, 3 strains of coronavirus have emerged, and these 3 are really important because they can cause severe disease. The first one is SARS-CoV-1, and it was described in China, and with cases reported between November 2002 and May 2004, and it caused the severe acute respiratory syndrome. MERS-CoV, so this is the Middle East respiratory syndrome coronavirus, and it was described in Jordan, and it still causes some periodic endemics in the Middle East, but fortunately, it has become contained there, and it has not expanded to other areas of the world. And finally, severe coronavirus 2, and this is the one that was described in December 2019 and is causing the current pandemic. So just to recap, in terms of the transmission, this is mainly through exposure to respiratory droplets, especially when in close proximity with an infected person. Sometimes through droplets or particles that remain in the air, and they're called aerosolized particles, and these can disseminate through various distances, and less commonly through contact with contaminated sources. So this is believed to be a much more rare source of infection. And although virus has also been found in various biological materials, including stool and blood, the role in transmission is unknown and probably does not play a role in transmission. And again, it's always important to recap the measures, the main measures to prevent the acquisition and transmission of infection, namely universal wearing of masks, maintaining physical distance, avoiding crowds, being outdoors better than being indoors, and the frequent washing of hands. And as Kimi already mentioned, more than 110 million global cases have been reported, and this is certainly an underestimate of the true magnitude of the number of infections, and almost 2.5 million global deaths reported. So, moving on to more specific vaccination issues, how do we develop immunity? And the development of immunity is the role of something that we call the adaptive immune system, as opposed to the innate immune system. So the innate immune system is a body response that is non-specific. It doesn't target specific pathogens, while the adaptive immune system is immunity is something that is acquired and more specific. So let's imagine that we have a coronavirus here, SARS-CoV-2, and in the case of SARS-CoV-2, the spike protein is really important because it binds to a specific protein that exists in the surface of cells, and that's called the ACE2 receptor. This is just a protein that exists in the cell surface, and then the virus binds to that protein because of the spike protein, and then it enters the cell. And once the virus is inside the cell, it can release the RNA, so the genetic material. And the genetic material can then be translated into proteins. So our body produces all the proteins, all the material that is required to create new virus. And then the virus is released into the bloodstream and into other organs or systems, infecting the body. Now, then various things can happen, and you cannot have, maybe you might not have symptoms, or you might develop mild disease or severe disease, but hopefully the body will produce an immune response, and that is triggered by certain cells in our body that can kind of digest the virus and present it to our immune cells, namely to T cells, specific T helper cells. And these cells, these T helper cells, then enable other immune responses, namely these B cells that are responsible for the formation of antibodies against the virus. Now, the production of antibodies, it's not the only mechanism to fight the infection. Other cells can be involved in that process, namely cytotoxic T cells. So when you hear about antibody and fighting the infection, you should bear in mind that's not the only mechanism that is involved in fighting an infection. And then these cells, namely memory cells, they can remain in our body for potentially months or even years, depending on the type of infection. And every time we encounter the same type of virus, the body is able to mount a robust defense against that virus or any other pathogen, in fact. And this is the principle of vaccination, to present something to the organism, to the body, that does not trigger the infection, but triggers the immune response, that production of antibodies and that cell-mediated immune response that will defend our body against future infection. And in fact, vaccines are one of the greatest medical advances of modern times. And you can see here the percentage reduction in cases, in this case in the US, after vaccination was introduced for various conditions. And in most of the cases, this has led to 100% reduction in the number of cases, so complete extinction of the disease. And there are now vaccines that protect against more than 25 diseases, and an estimated 3 to 4 million deaths are prevented every year because of vaccination. And if you're able to increase immunization globally, we estimate that we could save an additional 1.5 million people every year from dying. So there's still a lot to do in terms of globalizing dissemination and making it available to all countries. And I mean with regards to all these diseases that are listed here. And this is the difference between being vaccinated or non-vaccinated. This is a case of smallpox in 2 boys, the one on the left that was not vaccinated and the one on the right was vaccinated. And I think a picture is better than 1,000 words, and I think the message is clear here. So what types of vaccines do we have? And I'll start focusing a little bit here on the ones that are available for COVID-19 as well. So with regards to COVID-19, there are now 70 vaccines in clinical development. That means being actually tested in humans, and 181 more in preclinical development. There are 4 main types of vaccines: viral vector vaccines. They basically use a harmless virus that is altered, and that virus contains the genetic code of the COVID-19 virus, SARS-CoV-2. So it contains the RNA of the virus. Then there are RNA vaccines, so which is basically the genetic material, but rather than being inside of a harmless virus, it's a synthetic version of that genetic material. Then there's another version, which is all virus, which is basically a weakened or inactivated version of the SARS-CoV-2 virus. And finally, protein subimmunities, which basically use pieces of the SARS-CoV-2 virus. It could be the spike protein, which is the most frequent one, but potentially others as well. So with regard to viral vector vaccines, the main COVID-19 examples are listed here. So the AstraZeneca Oxford vaccine, the Sputnik 5 vaccine, which is the one that was produced in Russia, but also the Janssen vaccine and the Chinese vaccine. They are viral vector vaccines. There's already an example of a viral vector vaccine that was being used, which is the Ebola vaccine. Now, in terms of viral vector vaccines, there are 2 ways of manufacturing these vaccines. Either you use a weakened virus like the measles virus and others, and that's actually the method that was used for Ebola, but often that is a live virus that has been weakened and there's potentially some ability to replicate. So that method is not used in any COVID-19 vaccine. The method that is used in COVID-19 is a non-replicating viral vector, which is basically a completely incompetent virus that cannot replicate. It can infect the cells, but that's the aim, to infect the cells to deliver the genetic material, but it cannot replicate. It cannot spread an infection. So they are completely safe with regards to triggering an infection. And that's the example of the AstraZeneca and Sputnik. Basically, and to speak specifically about AstraZeneca, It's an adenovirus of a chimpanzee that has been modified, and then the genetic material is introduced into the virus, and then it's the same mechanism that I explained with the natural infection that triggers an immune response from the virus with antigen presentation of the virus proteins, and that triggers the immune response and the immunity. Then the nucleic acid vaccines, and the example are the Pfizer vaccine and the Moderna vaccine. Now this is a new technique, and the RNA is often encased into a lipid coat so that it can enter the cell. And then once the RNA is inside the cell, it starts being translated into proteins. And again, those proteins will then trigger the immune response of the body. Then we have the live attenuated or inactivated method. And this is being used with a couple of vaccines developed in China and one vaccine developed in India. So far, this methodology is not applicable to any vaccines currently available in Europe. And then the protein-based vaccines, and again, there are some in development, namely in Russia, Sanofi and GSK are producing one, and the Novavax vaccine and the USA. There are many examples of all these vaccines that with regards to other conditions where this methodology has been used. One important aspect is the efficacy or effectiveness of the vaccine. So efficacy relates to trial data, to a very controlled environment, while effectiveness is related to real-world data. Now, vaccine efficacy or effectiveness is measured by calculating the percentage reduction in the risk of the disease among those that are vaccinated relative to the unvaccinated persons. So let me give you an example. Let's say that we have an unvaccinated group where the rate of infection is of 10%. So 10 out of 100 people get the disease. While in the vaccinated group, only 1 out of 100 get the infection. So you can see that the difference is 10 minus 1, so 9% difference. Now, if you divide those 9 by the 9% by the 10% infection rate in the unvaccinated group, then you get the efficacy or effectiveness, depending on the setting, which in this case is equal to 90%. So when you hear about 90% efficacy of vaccine A, B, or C, this is basically what it means. It's the percentage reduction in the risk comparing the vaccinated versus the unvaccinated group in a relative manner. And this lists the main vaccines currently being used and their efficacy in clinical trials. And you can see that for all of them, very robust efficacies have been published, ranging from 60 to 95%. We cannot directly compare these rates because the clinical trials were done in different settings with different types of populations. But what this data is telling us is that all these vaccines seem to be excellent, with excellent efficacy rates. And now we're starting to have some effectiveness data. So we're starting to see how these vaccines are performing in real life. There's a bit of data from Israel, a bit of data from England and from Scotland that was published just a few days ago. But I'll just show you this graph with data from Israel, and where you can see a 1/3 reduction in hospital admissions among the old population since since their peak and since the vaccinations began on the, if I remember correctly, on the 19th of December 2020. So you can see that here that the number of cases, hospital admissions, and severe hospitalizations, they were gradually increasing. And then after mid-January, when you'd expect to see some effect of the vaccination program, the cases of admissions, hospitalizations, and the cases itself of SARS-CoV-2 infection, they all start decreasing. Now, one concern is about the mutant strains of SARS-CoV-2. And there have been three main mutant strains that have been described, one in the UK, the other one in Brazil, and the other one in South Africa. And the problem is that these mutations often give the virus the ability to escape the immune system. Sometimes it gives the virus the ability to replicate more efficient, in a more efficient way when once they enter the organism, or some of these viruses have the ability to bind strongly to that receptor, the ACE2 receptor, that binds to the spike protein, and therefore these mutant strains have the potential to cause, one, more severe disease, or two, they can increase the transmissibility of the condition. And obviously this causes concern, because we are not sure if the current vaccines are equally effective against these strains. New vaccines may be required, or perhaps booster doses against these new strains may have to be given. Although, you know, we are already kind of used to that, because it's not very different with what happens with the influenza vaccine, which needs to be given on an annual basis. And there's been a lot of debate about vaccination in patients with rheumatic diseases, and I've listed here 4 or 5 main points from a document that EULAR issued a few weeks ago. And I think the key point is that these vaccines can be used safely in patients with rheumatic diseases, as well as in patients receiving drugs that influence the immune system. There's no reason to believe that these vaccines can be harmful in our patient population and in the patients taking the immune suppressive drugs or the immune modulatory drugs that we prescribe. Preferably, the vaccine should be given when the disease is in a quiet phase. And let's say if a patient is due to start immunosuppression, it is also preferable if the vaccines are given before the immunosuppression is started, if feasible, because it may not be feasible, because sometimes we have to treat rapidly, and planning the vaccination should not delay the treatment if needed. However, specific data about the performance of the vaccines in patients with RMDs and patients treated with immunosuppressive drugs or immune modulatory drugs are not available yet. Although it is expected that the vaccination will be effective, there is a possibility of a decreased immune response to the vaccine, and also the possibility of flares, but this is largely speculative. And EULAR has stated that the real risk is of having a flare if the medication is stopped, and therefore stopping the medication is not advisable. Now, in order to answer a few of these questions that we have about vaccination, the EULAR has created the EULAR Coronavirus Vaccine Database, or EULAR COVAX database. And the objective is to inform, within some limitations, about the safety of COVID-19 vaccinations in patients with RMDs. It is a physician-reported survey, and basically we're collecting cases from patients with RMDs that have been vaccinated with any of the COVID-19 vaccines, and with or without adverse events. and hopefully we'll be able to demonstrate, within obviously the limitations of the data, that there are no major concerns with vaccination in our population. And it's intended to be a very easy and simple to complete survey with mainly checkboxes that can be completed quickly. The time to completion is between 1 and 4 minutes. And you know, I would encourage you to ask your rheumatologist to include your case in the database next time you see him or her. And I'll finalize with first one of the future challenges, which is the challenge of vaccine equity. And the UN Secretary General highlighted this problem a few days ago, because 10 countries have administered 75% of the vaccines, and 130 have not received a single dose of the vaccine. So I think this is a big challenge for the future, also because we will only be safe if the entire world is safe. So I think this is something that definitely needs to enter the political agenda at an international level, because the only way to solve this problem is if we solve it at a global level, not only at the country level. And finally, I will finish with a quote from an Italian colleague, that this is a quote that he mentioned while on a debate about vaccine skepticism. And it says, "The earth is round, gasoline is flammable, and vaccines are safe and effective. And all the rest are dangerous lies." So keep this in mind when discussing vaccines with other patients and healthcare professionals. And just a big thank you to all the people that have collaborated with me in the EULAR COVID-19 databases, the colleagues from the EULAR team, the data team in Manchester, colleagues from the steering group, the COVID-19 Global Rheumatology Alliance, national societies, and PARE, and also all the rheumatologists that have contributed to these data sets. Thank you all.
You're on mute, Susie.
Thank you. Thank you, Pedro. I think that everything was very well explained and very clear. And I think your last slide says it all. So it's quite reassuring, I think, for us patients. So we had a question here about vaccination. Yeah, from Dieter. Who should be prioritized concerning vaccination? And how can you as a patient realize this? What seemingly is difficult?
So different countries are having different policies. In general, stratification is being based on the interpretation of the risk for the various subgroups of the population. The main factor that has been incorporated in the prioritization of vaccination has been age, and there are obvious reasons for that, because age is indeed the factor that is most associated with severe COVID-19, and there's a clear gradient for age, and depending on the country, people on certain drugs, including immunosuppressive and or immunomodulatory drugs, have been prioritized as well. The position where they are placed really depends on the country's policy, and it varies between countries. So there isn't a clear answer to that question. There are reasons why I think patients with RMDs should be prioritized, because but it's you know, there isn't a unique answer to that question. It's really up to the countries to decide that.
Up to the policies of each state. Yeah. There's another question here. From Yolanda, how patients with RMD should prepare herself to vaccination, being treated with methotrexate and biologicals?
Well, that's very easy to answer. They should get the vaccine as soon as possible and as soon as they are offered it. There's a bit of debate with regards to methotrexate, if the drug should or should not be stopped at least for 1 week before or after each of the vaccine doses. And the ACR actually recommends that methotrexate should be held after each vaccine dose. However, I have to say that that's not based on evidence, at least evidence from COVID-19 vaccines. There is some evidence from influenza that methotrexate can influence the antibody response, but it's debatable if you should extrapolate that evidence to COVID-19. And then even among the ACR committee that developed that guidance, there was not full agreement, because there was only moderate agreement with regards to that statement. And so I think the key thing is just get the vaccine as soon as you are offered it.
Good. So another question from Getty. The difference between vaccine of Pfizer and AstraZeneca as regards effectiveness is high. Pfizer has 85% and AstraZeneca 65%. That means that all those vaccinated with AstraZeneca vaccines has higher risk to have COVID-19?
No, not necessarily. So that data is from clinical trials, so it's efficacy data. But the trials cannot be compared. They were done in different settings, different patient populations, so they should not be directly compared. And in terms of the real world data, at least the preliminary data that we've been seeing is not showing major differences between vaccines. So in principle, there's no reason to believe that one vaccine gives you more protection than the other. We will eventually know, but there's no reason at the moment to believe that.
Something related to that question. We have in some European countries, they don't vaccinate people over 65 with the AstraZeneca one. So, and they prefer to use it for younger people. Why is that? Is there a risk for older people?
So that depends a little bit on how we interpret the data. There's nothing to suggest that the vaccine is not efficacious or harmful in people above the age of 65. It's just about the existence of data or not in those populations. But again, it's something a bit political as well. If certain country has decided that, I think that it's acceptable. It's also about politics, but there should be no concern from patients with regards to that point. If they are over 65 and offer the AstraZeneca vaccine, it's absolutely fine.
So I'll tell my mother, who is has been just vaccinated yesterday with the AstraZeneca. She was really worried about it. So I'll tell her that it's all right, not to worry.
It's all right. Yeah, she shouldn't worry about that.
Good. So another question from Ofra. Have we answered that? No. What about long-term efficiency for RA patients?
So that question applies not only to RA patients, but first of all to the entire population. So we don't know, after being vaccinated, we're not sure how long the immunity will last. And obviously, if then there are mutant strains that become more prevalent, we may also need new vaccines against those strains. So that is still to be known. How frequently we'll have to be vaccinated, How long does immunity last? There are still a lot of unknowns with regard to those questions. There's also the theoretical risk that immunity might not last as long as for people without an underlying immune dysfunction, and that would be the specific issue with RA and lupus and other conditions. But again, we don't even know if that's a real concern. Probably not, but eventually we'll have the data. So we cannot say much about that at the moment, I'm afraid.
Okay. So another question from Andre. Which is the best for people on biologics regarding the effectiveness?
They're all the same. As far as we know at the moment, they're all the same. They're all very good.
The same.
Yeah, they're all very good. Impressively good, I have to say. I think at the beginning of this pandemic, if we were told that the vaccines were being so effective, many of us would say very unlikely. They're all very good, and they're also performing very well in the real life scenario.
Can I say I had a funny response to that? And the best vaccine for you is the one that's going into your arm right now.
That's good. But you've talked, Pedro, about the live attenuated or inactivated, that we don't have any under construction of that sort now, you said.
Yeah, so, well, the large majority, and certainly not any of the ones being utilized at the moment, they're all, well, the majority are either viral vectored or mRNA. But even the ones that are being studied, there are no live vaccines at the moment being used. There are a couple being studied, but they're not being used yet.
But if they were, they wouldn't be appropriate, suitable for people with on biologics. Is that correct?
Yeah. Yes. So if at any point in time in the future, a live vaccine, a live attenuated vaccine against COVID-19 is marketed, then patients on biologics, steroids, immunosuppressive drugs in general, they should not take that vaccine.
That's good to know.
Rule.
Yeah, that's good to know. Another question, does the 2 doses should be from the same company?
So based on current knowledge, yes. And I think that's the right attitude at the moment. There are ongoing studies to look at the possibility of mixing vaccines. We'll have to wait for those studies in order to know if that's an adequate approach. So at the moment, the answer is yes, based on current knowledge.
Okay. And does a relatively recent dose, 8 days before, of pneumovax have any impact on the effectiveness of the AstraZeneca vaccine?
No, it shouldn't have.
It shouldn't have. Okay. Thank you for the presentation. Very interesting and educating. If a patient has COVID-19 but no symptoms and she or he vaccinates, is there a risk to develop severe symptoms? If so, should people do a real-time PCR test before the vaccination?
No, people should not be tested, and there's by symptoms, I'm not sure what that means, but if it means symptoms of the disease, the answer is no. Obviously, like any vaccine, there might be mild reactions to the vaccine, like pain and soreness, and potentially there could be a stronger reaction to the first dose of the vaccine for those that had infection in the past. It's the same thing that happens actually with the second dose of the vaccine. People tend to have a stronger response to that dose, but there are no concerns in actually having the symptoms of the disease. No, not at all.
Are there any studies regarding the combination of doses between vaccines produced using the same technology if there is not enough doses from the same vaccine for mixture between Pfizer and Moderna?
Yeah, no, there are no studies. Those are being done, but at the moment we don't have any data about that.
Okay, and I think this is my last question. Have there been any reports post-vaccination about autoimmune flares?
Not to my knowledge.
Okay, thank you very much. That was really interesting. I see no further questions. I hope I haven't missed any. Okay, thank you very much both, Kim and Pedro. That was really interesting and informative. And we appreciate you spending this time with us and answering our questions. Thank you very much. And thank you all for attending this webinar. Have a nice evening.
Thank you. Bye-bye.
Bye-bye.